Thanks. And turn this over to Indra for the presentation today. And folks, sorry, I said turn it over and then folks, if everybody could please introduce yourselves in the chat, that would be great, just so we get to know each other a bit. Thanks, Indra.
All right. Thank you for having me. Good to see you all today. Like Betsy said, Indra Lusero, they, them pronouns. I won't go into too much depth about me. I'll tell you just a tiny bit about Elephant Circle, and then I'll dive in because there's so much I want to share with you, and even more than we can possibly cover today. So I founded Elephant Circle while I was in law school because it became apparent that the kinds of work that I felt needed to be done, learning what I was learning about childbirth and the law, was not being done. And so there needed to be a whole new kind of work. And that's where Elephant Circle came from. We're called Elephant Circle because we're inspired by how elephants give birth in the wild. The whole herd circles around the laboring elephant, stays for the duration of labor, offering connection and support, nurturance, but also protection and defense. And that's what we try to do at Elephant Circle, which I think is a good segue to the subject that I want to spend time talking about with you today, which is the intersectionality of birth justice, and particularly as part of that, accountability. Go ahead, if you have questions as I'm going, you can type them in the chat. Betsy will help transmit the chat questions to me, but you're also welcome to just come off mute if you have a question while I'm going. But I'm going to share my screen because I do think that some of the visuals can help reinforce what I'm talking about. So here we go. All right. So by now, it's a pretty common phrase, this idea of intersectionality. And we know that it means that we have multiple identities, that many parts of ourselves influence our experience in the world. But I think a piece that gets lost is that this term intersectionality, which was coined by law professor Kimberle Crenshaw in 1989 in this law review article, was really about accountability. So what she was talking about was not just the fact of our intersecting identities, but the way in which the reality of intersecting identities makes accountability less available to certain people. So, for example, we have here this illustration of an intersection, which is, what Kimberle Crenshaw was talking about. And on one axis, she was talking specifically about employment discrimination that Black women experience. So on one axis, Black women are experiencing discrimination on the basis of race. So let's say that that's going this direction in the intersection. But they're also experiencing discrimination on the basis of sex. So that's going this other way in the intersection. The way that employment discrimination law worked when she was critiquing it and still works today is that essentially you can get accountability on the dimension of race, which is this green circle down at the bottom, or you could get accountability on the basis of sex, which is this green circle here at the top. But it's practically impossible to get accountability for the nexus of that specific harm that is there in the center, that is at the intersection. And she talks in her article about specific cases where essentially Black women were denied the accountability from our anti-discrimination laws because of this failure, because of the way that those laws were not built to address this intersection. So I think that's really relevant to what's happening with the kinds of harms people are experiencing in the perinatal period. So our questions today are, what kinds of harms do we need accountability for? How can we get accountability for those harms related to birth? And why does accountability matter? So starting with what kinds of harms, we're going to use this little case study. We've got Anna. She's 30, Latina. This is her second pregnancy. She's got private insurance. Her boyfriend is Black. She wants to give birth vaginally. And what happens with Anna is, having had a traumatic birth when she was 23, she was alone. She was told she needed an emergency cesarean section. She didn't really feel like she had a voice or an understanding of her options. She came to regret that, felt like she was pressured, wondered if she really even needed that surgery. It was hard recovery. So during this pregnancy, she's much more engaged. She's reading everything she can get her hands on. She's got a really engaged partner. She feels supported. She seeks out the care of a midwife, thinking that will help her. She really wants to have a vaginal birth this time. She thinks about having a doula, but ends up feeling so supported by her midwife and her partner. She can't afford it, so she decides not to have a doula. Her midwife is a nurse midwife who she sees for all of her prenatal appointments. But when she goes to the hospital in labor, it turns out that her midwife isn't available. She's seen by the OB on call. The OB on call tells her that she's got a score of 59 on the VBAC calculator. And that means she will not get to attempt a vaginal birth. She's going to have a cesarean section because of this score on the VBAC calculator. They've got a policy at this hospital. She didn't even know she had a score, much less what it was, much less that it would prohibit her from having the option to birth vaginally. She tries to express how important this is to her. Her partner starts to argue with the provider because he knows, he's feeling protective of her. The OB is feeling threatened. It escalates. Hospital security is asked to remove her partner. She again tries to advocate for herself because it's really important to her that she not be alone. That's dismissed. She's told she needs to be prepped for surgery. She ends up having the surgery. And afterwards, she's feeling really betrayed. Like, this is not okay what happened to her. And she's wanting to know, how can she get accountability for this harm? So this is our question. This is one of the kinds of harms that we need accountability for. Let's think it through in terms of the intersection. On one dimension, we have the fact that she was given this surgery and maybe it wasn't even medically necessary. So we're going to call this dimension, malpractice. And this is probably the most common form of accountability that people think about when they hear about harms that happen during healthcare. Was this, the right procedure at the right time by the right providers? Was it done without negligence? But frankly, this is Anna's the least of Anna's concerns. On this other dimension, we've got, she feels, she has this hunch that she was treated differently. She wonders if it's partly that her partner was Black, that he was treated differently, that she was impacted then by that. She also wonders if because she was Latina, she was treated differently. She just has a feeling. So there's this potential discrimination dimension. But then there's this other layer of things that she doesn't even know about, but are at play here. So these are going to be these dark red lines in the intersection. There's also this dimension of what we'll call structural malpractice. This is just something I've made up, just for the sake of today's workshop. This is the fact that she doesn't know. The reason why she didn't have access to her midwife that day is because they had just shut down the midwife practice. They had decided that it wasn't making enough money, and they thought they could get, better revenue if they just excluded the midwives and just worked with the doctors. She doesn't know this, of course, but this is a factor in what happened with her care. The other thing that she doesn't know about, but is definitely a factor we're going to call structural discrimination, is the fact that this VBAC calculator, which is a tool, it's a real tool that exists. It was funded by the National Institute of Health, federal funding. And this tool it does have racism built into it. It assesses people based on race, and there's only 3 categories: Black, Hispanic, and white. People who do not self-identify when this tool is used on them. Body mass index is also one of the characteristics of how people are assessed, as well as their previous reasons they got a previous cesarean section. What we know about this VBAC calculator is that, in fact, it directs more Black and Latina folks away from VBAC. So essentially, it results in more cesarean surgeries for Black and Latina folks because of the scores that they get on this calculator. And in fact, 60 is the cutoff. In some systems, how they use this tool is they created just a blanket cutoff. If you don't score above 60, you can't even attempt vaginal birth. So she didn't know this was happening, but that's a part of what's going on here. So her question is, how can she get accountability for all of this, really? She wants accountability for all of this. Probably more than anything, though, she wants accountability for the fact that she didn't feel heard. She wasn't part of this decision-making process. And I think of that as encapsulating this experience of being in the intersection. Her experience specifically as a person in this intersection was completely overridden, basically. And what's the accountability for this? Some people have come to describe this kind of harm as obstetric racism. It's this particular confluence of factors that result in this kind of harm. It's also known as obstetric violence, that the way that she essentially in this situation was forced to have a surgery, that there's a specific kind of violence here in this context. I wanted to share this example. Anna is, a fiction that I created based on knowing a lot of these stories, but this is one of the real stories of obstetric violence that I've worked on. This is a forced cesarean surgery at Staten Island University Hospital, where they even wrote in her chart, the woman has decisional capacity. I've decided to override her refusal to have a C-section. Her physician and the hospital attorney are in agreement. Literally, this was the decision-making process. This is really, really how it went. We've also collected in this almost 90-page brief the range of types of harms that we know are happening in the perinatal period, that we essentially believe are in this intersection. And we've broken it down by the national anti-discrimination laws that we have, which do exist in these limited categories, which is part of why they fail to capture the kinds of harms folks are experiencing in the intersection. But we do here in the field. I want you all to know that in the field, we do know the range of harms that are happening. But what we're lacking now is connecting what we know the harms are to avenues for redress and accountability. So let me tell you a little more about what those avenues for redress and accountability are. We've created this resource for everyday people to defend human rights during labor and birth. In this, we've created this sort of chart of 9 ways that people can say what happened to me was not okay. We've done this because folks immediately think of the legal avenue, which we have in this 9th box here in the bottom right. But since that is so underdeveloped right now, we really wanted a way to help folks think through more kinds of options that might be more immediately available to folks. So we encourage people to kind of do a pro-con analysis for themselves, depending on what their capacities and needs and interests are. Certainly starting with just talking about what happened, writing it down, giving direct feedback, moving from that to filing formal complaints with varying degrees of utility and success. My favorite is probably work the system. In this kind of form of accountability, we encourage folks to think about where they're situated, who they know, what they're good at. And this has helped folks do things from getting media, social media attention, changing hospital policies, organizing community events, and really connecting with people and coming to some sort of healing as opposed to getting accountability, contacting state representatives, media, direct action, and finally filing a lawsuit. Part of what we're dealing with in terms of this intersection and the kinds of accountability that people may or may not have access to is this many legal issues come into play. So there's human rights dimension, there's the civil disobedience dimension, there's informed consent, negligence, intentional torts. There's administrative law issues, insurance law issues, contracts, criminal defense, constitutional law, antitrust dimensions, family law, family regulation system, Indian law. And the way that the legal field works, somewhat like healthcare, is that it's much more about specialization now than it was even 50 years ago. So it's very hard to even find a professional who can think about the intersection. You can find somebody who can think about a part, but it's very hard to find somebody who can draw together all those parts and help somebody strategize in their situation, which elements might be most salient and might help them get redress. There's also the important distinction between both federal and state, as well as legal versus institutional. This is another thing that adds to the complexity of this intersection. Some of the factors in the intersection are controlled by the state, but some are controlled at the federal level. So this brief that we sent to the Office for Civil Rights was specifically talking about the federal anti-discrimination laws, and the Federal Office for Civil Rights does have nationwide authority to investigate anti-discrimination, to investigate discrimination across all of the states. But then each state also has civil rights commissions that function sort of like that Federal Office for Civil Rights and does that anti-discrimination work at the state level. Most hospital regulation, provider regulation, insurance regulation, malpractice are state level issues. I could go on, but this distinction between the federal and state is part of what's at play here. The other thing that's at play is the distinction between the legal and the institutional. For example, in Anna's situation, this hospital policy that they won't support vaginal birth after cesarean if you score below 60 on the VBAC calculator, that's an institutional policy. So it's purely existing at that hospital or health system level. The state probably doesn't even know about that policy. So the legal avenues for redress that exist at the state can't quite reach the way that that policy impacts Anna. She can't, for example, go to her legislator and say, this hospital has this policy that I think is discriminatory, even if she learns that it's based on this discriminatory tool, which, by the way, was funded federally. If she takes that to her legislator and says, what can we do about this hospital's policy? The legislator is going to be hard pressed to have anything to do, because the state legislature doesn't really have any existing ways to say to the hospital, this policy is wrong. And this is, again, partly because of how our anti-discrimination laws work. They weren't built around the intersection or solving the problem of accountability at the intersection. They were built in a time where discrimination could be written down. You might have a policy at a hospital that says, we will not treat any Black people. That's much different than the policy that we won't attend somebody in a vaginal birth if they score under 60 on the VBAC calculator. So you can see how that kind of institutional policy creates a barrier to legal accountability. Which, of course, leads us to why accountability matters. I think most people have a feeling in their guts about why accountability matters. And that is absolutely true. I encourage you to trust that sense of why accountability matters. Kids know this. A lot of times kids will spontaneously express dimensions of liberty and justice as skepticism about, is there any accountability? Who's in charge here? And, you know, if something happens that isn't right, you want somebody to acknowledge it. So I used this image of liberty, which includes not just the scales of justice, but also the sword, to kind of remind us that when we're talking about birth justice, of course, we're not just talking about the scales, but we're also talking about the sword. And the sword, you know, is an important dimension, because essentially we can't have justice if it's not protected by the sword. This is certainly what history has told us. Accountability also matters because we're living in a time where we're in conversation with governance at the international level. And on this issue in particular, the United Nations has taken a close look. This incredible report from 2019 specifically focused on mistreatment and violence against women in reproductive health services, with a focus on childbirth and obstetric violence. And in this report, they make it plain that they're seeking to lay a foundation for states in upholding human rights obligations. And how can states do that? They can do that by developing appropriate laws, policies, strategies, complaint mechanisms to ensure that a human rights-based approach to healthcare and accountability exists. So accountability on this issue matters because it's part of being in the international community of governments. Another important thing to know about why accountability matters is people want accountability. This incredible work done at the international level in the What Women Want campaign collected 1.3 million answers from women worldwide about what they want in their healthcare in particular. And the vast majority of responses was respectful and dignified care. You can see the top 5 responses here. Many of them were very specific to the context, but as the themes emerged, this theme of respectful and dignified care emerged across the world. And I think what we know about respect and dignity is it's linked to accountability. You can't really have respectful and dignified care if you don't have some sort of system that shines a light when there are violations, that acknowledges when there is harm, that offers some pathway for healing and redress. More local, there has been this incredible work done by the Birthplace Lab on the Giving Voice to Mothers study, in a way similar to this What Women Want effort, but really specific to the US context and the pregnancy and childbirth context here. And again, what people want, what voices are saying is this respect and dignity is a top priority. People want to know that their voice matters and that there's a way for their voice to be factored in. Another reason why accountability matters is it's feedback. A lot of folks in the healthcare space have heard about and think about this idea of quality improvement. And quality improvement and safety are really grounded in this idea that these systems should be learning systems. We're not always going to get it right, but when we don't get it right, we want to know why we didn't get it right so that we can fix it and keep improving. This is true clinically. This is part of how this system works. Providers will review cases, review bad outcomes, trying to figure out what they did wrong clinically. But what's lacking in this system right now is a feedback loop that helps the system see where it's failing, that helps these interconnected pieces see what's falling through the cracks, how this whole system could do better. And of course, this graphic is titled US Healthcare System Simplified. So even this simplified map of the US healthcare system is complex. You can see from this picture that an accountability loop would be tricky. It's hard just at a glance to know where you'd set it up and how many, points of contact you'd need to make. This is part of why accountability is important, because if this system is going to learn, there's got to be places where feedback reaches the right people. Essentially, that's the key ingredient, is feedback has got to reach the right people. And what's happening now is it's just not, because it's not built in to this system. Accountability is being seen as part of this healthcare quality competency framework. It's right here in this, top piece of the pie. Of course, all of these pieces are important to quality competency, but without this idea of quality review and accountability, you really struggle to have the kinds of things that you need for true quality. So accountability is highly valued at even the most, standard setting institutions. But the question, of course, is how are we gonna get it here if it's not here already? Who knows the kinds of things you need to know to build a system of accountability? Coming back to Kimberle Crenshaw, she says, it's not always easy to reconstruct an accident. In terms of this expertise at the intersection, who's going to help us figure this out? The skid marks and the injuries are just, they don't indicate what occurred. Like, you can't tell when things happen simultaneously, which frustrates efforts to determine which driver caused the harm. She found, now almost 30 years ago, more than 30 years ago, in these cases, the tendency seems to be that just no driver is held responsible, no treatments administered. The involved parties simply get back in their cars and zoom away. This is the state of things when it comes to harm in the perinatal period. There's just no drivers being held responsible, no treatments even being administered. Parties are, if they're lucky, getting in their cars and zooming away. If they're not, they're, being drug over to the sidewalk. But fortunately, we do feel like we have some strategies to offer. This is what Elephant Circle's trying to do with this conundrum. We've got a birth justice tribunal coming up this year, which will be a symbolic presentation of the types of harms presented in a forum, a public forum, where we also present and talk about potential remedies, make recommendations for remedies. We've got this blueprint for birth justice, which we think helps contribute to that thinking that needs to happen if we're going to tackle the complexity of what's in the intersection. We've also got a birth equity policy platform, so we can start to think long-term about what's going to need to change, what kinds of things could we make policies do that can bring more feedback loops, that can bring more avenues for redress, that can even just give us data about the nature of the harms, where they're happening, when they're happening, who might need the feedback. And of course, we've got the birth rights resource. We're also just trying to reach people directly, people who've experienced harms, people who want to prevent harms, providers, doulas, pregnant people themselves, families. Partly, as we have learned from Kimberle Crenshaw's incredible work, is the value of naming things. Her creating this term, intersectionality, hasn't totally solved the accountability problem she was pointing out, but it's certainly transformed how people are able to identify and think about what kinds of harms we need accountability for. So part of our work is that kind of work. We're trying to name the things so that we can begin to shed light on them. With our brief to the Office for Civil Rights, we have been in conversation directly with the directors of that office. We know that this administration is committed to addressing some of the inequities in perinatal health. So this Office for Civil Rights feels motivated, feels like now's an opportunity where they can look at the mechanisms they have. We're hoping through this brief that we can help them do their job by doing some of that thinking, by articulating some of the legal issues that we know that they'll be encountering and helping them connect the dots to the kinds of harms that people are having. We're also hoping to encourage more people to use this reporting function to the Office for Civil Rights, because when they start to hear more about these things, they're going to be more inclined to take action. So this is a handful of the things that we are aiming to do to tackle this problem at this moment. But of course, there's more to do, and I think that's where you all come in. Hopefully, you can see some pathways where you can help develop what's possible in this field. So I will leave it there for the moment. So potentially I could field some questions. We could have a little conversation. I know this is a lot.
Thank you, Indra. I'd like to open up for questions, but first I have one, which is, where can we find the blueprint for birth justice and the birth equity policy platform?
They are on our website, which I could put a link to the chat here in just a moment. The mobilizing the Office of Civil Rights report is also on our website.
Okay. I see. So the birth equity policy platform is under the tag birth justice at the bottom. Okay, found it. Thank you. Questions, comments? What can philanthropy do? Is anybody out there doing this kind of accountability work in your own funding region? Stephanie.
Yeah, I mean, a few thoughts, and thank you for the presentation. Super interesting, and gathered a lot of resources from your talk. So really appreciate that and all the work you're doing. Yeah, we at California Healthcare Foundation, we're big believers in measurement and accountability. And when you're in that space as a funder, you have to take the long game, because it takes a while to develop this stuff, and would love to have more funders. I historically, in my 13 years of funding in maternity care at CHCF, have had slim to no co-funders in the measurement work that we've tried to do. We funded Listening to Mothers in California, which was a state-based rendition of the national work, and then paid to have it fielded in Spanish and oversampled Black birthing people. And although that work has last done, and it's like $1 million to do the survey, so it's not like an annual thing. But we're interested. I know there's a group that's interested in doing another national pass at that survey, and highly recommend it. It's a gift that keeps on giving, and it gets to a lot of, not everything, and definitely need to raise up the intersectionality issues in that survey if I did it again, but is a really good, been very useful for getting laws passed in California and things like that. The other thing I would mention, which is a sidebar weedy topic, but again, if anyone likes the weeds of measurement, they're the CAPS patient experience surveys. Those are the federal standard by the Agency for Healthcare Research and Quality, and they're the ones that the Center for Medicare and Medicaid Services requires. So all Medicaid programs have to field these surveys, but there's no maternity CAPS patient experience survey. There's a hospital survey, but there's no. So I've been trying literally for my whole career. I worked on it at RAND. I worked on it now when I was here. And that's something that if anyone has interest for law, pushing on the federal government to actually develop that with maybe some help from philanthropy. It's an expensive endeavor, but it's just unacceptable to me that there's dialysis caps and nursing home caps and hospital caps and every kind of caps you can recognize. And I'm not selling that survey, but that's one that it's already got a place. And so if you had one that was well developed, the deployment arm of that is like, boom, CMS says it's required. Now everybody has to field it and report on it. Talk about accountability. So I'm happy to talk more. I'm a measurement geek because I really believe in it. So if anyone likes this subtopic, I'm happy to have a little sidebar on it sometime.
And that's a good example too of where some policy work can be done now, even as part of a long game. Like, we're gonna push for creating this measure, knowing that once we have the measure, we can push for more accountability feedback loops that are related to the data that we get from that measurement.
Thank you, Stephanie and Indra. Monica. Where'd you go? Oh, you're muted, Monica.
You guys, it's almost Friday. It's almost Friday. I have been thinking, first of all, thank you. I want to make sure you hear that. Thank you so much for your presentation. I've been thinking a lot about accountability, because I feel like in philanthropy, at least with the funders that, you know, are in my circle, we have spent a lot of money ensuring access to healthcare, but we have completely forgotten about quality, and that piece of what happens when a Black person enters the doors of a hospital, like from the receptionist to when she's giving birth, right? And like, that's eating at me, because I don't know what to do. Hospitals don't want to play. And I think we have a couple of things that we're doing with some of us here. Andrea, maybe we're going to talk about NCQA, right? That work of really creating a measure for maternity care. And also Dr. Karen Scott has her measure for measuring obstetric racism, right? But it's difficult to implement because nobody wants to look no hospital wants to look at that data, right? And see the hard data of, yeah, we're being clinically racist to our patients. And I don't know what to do, but thank you. So much
Yes,
work.
yes, that reminds me of, I think, the value in thinking about how human rights are a health outcome, not just that quality matters, but that this is a measurable outcome. Just like we can get data about other clinical things, we can get data about people's experience in the process of getting healthcare, and whether it's aligning with even just basic standards for human rights or civil rights or basic rights.
Thank you. Andrea, was that your comment? Would you like to speak to that?
Yes, and that was with respect to what Stephanie was mentioning. And forgive me for putting the National Birth Equity National Collaborative for Infants and Toddlers, that on the brain. But it's the National Birth Equity Collaborative, and they had developed a patient-reported experience measure for Black mothers. But in order to get it included in the CAPS, they have to validate it for other populations. They're working on that now. And so if they're able to get questions from that survey included in the CAPS survey, as Stephanie mentioned, that is going to really go a long way in terms of holding the healthcare sector accountable as well.
Yeah, thank you. And Andrea, you connected me with them, and I would like to have them on, Susan Perez from National Birth Equity Collaborative, on to talk about that data. And Stephanie, thanks for that offer. I encourage folks to take Stephanie up on that. And I think and if it's not there now, I will put it on our resources, is the report that California Healthcare Foundation has done about how how they led the effort to literally lower the C-section rate in the entire state of California by pulling many different levers in so many creative ways as well, by holding hospital systems accountable. And that reminds me that there are, I wish it didn't come to this, but when there is a maternal death, I think more and more communities are taking to protesting a local hospital, like that level of accountability, to try and get at what are the local institutional policies that impact and what can be done from there. But that's a lot of labor on the people who are impacted the most. So I don't want to rely on that. But if you see leaders in your community, is my point, if you're a place-based funder and you see leaders in your community activating in that way, that's a great way to support. Oh, yeah. Thanks everybody for the resources. Other questions and comments? I have a comment, which is, Nick, Kenya, go ahead.
Hi,
Nick,
y'all. Hello, and please excuse my coming late to the party. Looks like y'all been doing some fun stuff. I've actually been at the Capitol in Texas, trying to get 12 months postpartum Medicaid today, testifying. But I wanted to share that I don't know how many of you all are in Texas or know about the issues specifically in Texas, but I serve on the MMRC in Texas. And one of the things that has been super challenging for us is our redaction process. We're the only state in the country that redacts. And so we also, the hospital, we get our information by vital statistics records. And so we get like this really random data set for each individual mom who passes away. And sometimes we get informant interviews, sometimes we get prenatal workers, sometimes we get a Medicaid, record. And other times we don't get any of that, or we get a death certificate that's not completely filled out, and all the different things. And I have been advocating in the community advocate position for the redaction to be taken away. It takes a lot of time, it keeps us behind. And there are very specific trends that we see that we cannot laser focus because we don't know the region, we don't know the city, we don't know the hospital. And we have to go back and even ask for maternal level of care. So sometimes we don't know if it's because they don't have the resources or if it's because they're just completely negligent, right? And I'm looking at these cases, case by case by case. And so everything that Indra has been saying and you all have been talking about is so spot on. And if you want to get it done anywhere, I invite you to come to Texas because we really need you here.
I'll mention that that's a really great example of the challenge at the intersection, because part of what's happening with that redaction, and Texas is extreme, but data privacy and data confidentiality rules happen all over. And to some extent, those rules are in conflict with other priorities and other needs that we have for the data, which is why we need folks with a special ability to think about the intersection. We don't just need folks who are, data privacy analysts, because it's not entirely a data privacy problem. It's a problem of priorities and values. And what I think we need right now in the field is putting more resources into building our capacity as a field to do that kind of work, to have the intersectional thinkers who can bring all these pieces together. I think if we don't get that, we're just going to reinscribe some of these problems at the intersection. They might be different. We might find a new direction that we're able to solve, sort of, but we're just going to keep having that intersection problem.
Stephanie?
When you say priorities, I mean, to me, it comes down to, and I'm a 5th generation Texan, so I I feel your pain. I live in California though. The thing is just when are we going to put the patients first in these activities? And I don't mean, and that's something that I don't know if it's lobbying, which we don't do, or how that comes about, but we need some kind of really movement, kind of narrative change kind of thing where we protect providers. And I'm not saying providers don't deserve protection. People work very hard, mistakes get made all the time. We're all human. I don't mean that. But when things are redacted to the point where you can't learn from the loss of life and stuff, there just needs to be a conversation, because that's the same argument that's also made for like why you can't have public reporting by named hospital, which we have achieved in California for some measures, but not for ones that he hopes anyway. So this is the kind of like movement building that I feel like a lot of us in these funding circles, the federal government's not going to do this. It's going to take pressure from outside for us to. There's got to be some middle ground here where we don't throw nurses under the bus or whatever, or providers who are well-meaning, but we also don't say like sorry, we're not going to learn from people dying and how we can have that not happen. I mean, that just doesn't make any sense.
And I'm glad you mentioned not lobbying, because part of the conundrum we have here is in who has a voice in order to lobby. There's a good chunk of those folks who don't lobby for the reasons that they don't lobby. And we can't deny the reality of who does then lobby. And right now, the reality is that who does lobby and who doesn't lobby and who would lobby if they had a voice equals the status quo.
Indra, I know we're coming up on time, but I want to just echo that and say that I lobbied for the first time ever today. I testified for the first time ever today.
Yeah.
And that's just not a space that I have wanted to engage. And if you're receiving, funding and you're a 501c3, you have to be super careful and all of that. But I can also tell you that I've been working to get doula reimbursement for with Medicaid right now. And I see these advocacy organizations circumventing the Black legislators with lived experience. I see them picking and choosing who in community they bring in to, their efforts. And I have been, kind of calling it on the carpet a lot in the last couple of months that like, this is not okay. And who are we centering when we're doing this, and what, again, are our values and what are we truly trying to accomplish? And just when you were talking about it, it struck a chord with me because I am seeing it play out in real time right now.
Yeah.
Today, right.
I would just want to know, I know JC, you were going to say something. I didn't know if it's still relevant.
It was kind of actually to that point, in many ways, the work that you did in Colorado to get the birth equity bill package covered. I think the approach you all took really tried to prevent some of that. I don't know if you have a second to talk about that.
I think what you're referring to is, yeah, we tried to not just lobby on some issues related to the perinatal period, but we tried to have a lobbying strategy that accounted for these dynamics. One of the dynamics being that, the hospital association and the insurers association and the providers associations generally set health policy. And in order to change the conversation with that being the reality, and we're a tiny little group with way less resources than all of these folks combined, was to very systematically and strategically include community and voices in stakeholder conversations where, typically you don't invite community. And it's only typical because these entities are used to being the policymakers. They're used to being the stakeholders. So we had to not just say, this is what we want the new law to look like. But we had to say, when we're talking about what this new law is going to look like, it's going to sound different because different people are going to be around the table. That to us felt like the only way to successfully change the policy. And I do think we figured something out. It did change the conversation. It definitely changed how those policy conversations went because of who was in the room. Thank you, JC.
We're wrapping up, and I would like to close with a few things. The first thing is that I'm hearing a call to action that we can continue a conversation, and that call to action is more funders around the table for funding measurement and maybe coming together to think about what kind of impact funders can have together. And Indra, your call about we have to focus on the intersectionality of accountability. And that's your whole presentation, right? So I'm wondering if there's interest in a further conversation, and if so, then Funders for Birth Justice and Equity, I can work to facilitate and set that up.
Betsy, Monica has her hand up.
Thanks, Monica.
Just one last comment. I think, Indra, you use data from the Giving Voice to Mother survey, right? You guys,
Use-
we use that data a lot, and they could use funding to support that work that we use in all the presentations. So just putting that out there.
Yes, we use lots of data, and I know Tanya put in the chat, I will be talking about the relationship between data and policy in a talk later this month, I think.
Thanks. I will send
Yeah, and
these
to
resources
underscore,
out.
sorry,
Yeah,
Betsy,
go
but
ahead.
really to underscore what Monica just said, the Birthplace Lab has been doing some solid work in this area, and please look at them as a potential funding.
There's the birthplace, there's two really good surveys. There's the Birthplace Lab, and then there's Listening to Mothers national survey that's done by the National Partnership for Women and Families. And I know right now, Monica and I and several others have been working hard to get to the finish line on what we need for the Listening to Mothers survey. And then both of these surveys are really important surveys. And without data, we don't have any legs to stand on. We gotta fund this stuff, even if it's, you know, small amounts add up to something. We got a lot of people on this call. So, and Indra, maybe you can, I think it's really important for people to appreciate how important it is to have that data for people to do work like the work that you do. Because without it, we're just making claims and we don't have the backing of a representative sample survey. And that's really, it's really important, especially for like, for true lobbying, if we need to do that.
Yeah. And that's what I'll be talking about more at my next presentation, but I do want to say, just maybe in closing, sorry, Betsy. Right now, there is way more investment happening in measurements and data than there is in the advocacy and even in the capacity for advocacy to be able to leverage that data. And I'm worried about there being too far of a gap, and it's going to take too long before we're able to leverage that great data if we're not investing in the complement, the other piece of the puzzle.
All right, that's a continued conversation as well. Thank you. And Merck for Mothers, it sounds like you've joined there are a number of funders on this call who are funding the Listening to Mothers survey. And it sounds like you could reach out to Stephanie, Monica, or Wilna for more information, as well as the national partnership. I want to wrap up. Thank you, Indra. I want to attend every presentation that you do. Folks, Elephant Circle is a critical piece of this movement, and also, you may know, is a fiscal sponsor for many emerging organizations, including Funders for Birth Justice and Equity. It's another very important role they play, as well as having taken on several birth centers recently to rescue those. So they're now in direct service. Thank you, everybody. Look at our website, fundersforbirthjusticeandequity.org, for our next monthly learning series presentation in April. It will feature a report done by Kellogg Foundation and future webinars. Indra, thank you.